Bismillahirrahmanirrahim. Assalamu alaikum and good morning to all. I am Dr. Nabiha Rizvi, consultant nephrologist at Hijaz Hospital, Lahore, and I am going to moderate the session, free paper session today. Before starting the session, I would like to clear one thing, that the time for each participant is 6 minutes, so please try to be in time. To formally start the session, I would like to invite the chair of the session, Professor Dr. M.H. Usmani, who is Professor Nephrologist in National Medical Center, Karachi. Please, sir, I welcome you on stage. The co-chair of the sessions are Dr. Abdul Manan Junejo, who is Professor and Head of Department of JPMC Karachi. The second co-chair of the session is Dr. Muhammad Abid, who is Associate Professor and Head of Department of Sheikh Zayed Hospital, Rahim Yar Khan. Please, sir, have seats. Thank you.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم السلام عليكم. Now inshallah we'll start this session. I think the attendance is poor because we came back very late at night. So I will call the first presenter, Dr. Azhar Ali Khan, to present his paper on new onset diabetes after transplant and associated risk factors. Dr. Azhar Ali Khan from Sheikh Zayed Hospital.
Thank you, sir. Bismillahirrahmanirrahim. A very good morning to all of you.
And excuse me, we'll have the question answer session after all the papers have been presented.
So today I am going to present my study, which is new onset diabetes after renal transplant and associated risk factors. The co-authors included Dr. Azhar Wahid Khan and Professor Waqar Ahmed. The objective of the study was to evaluate the incidence of new onset diabetes after renal transplant and associated risk factor. It was a prospective study and conducted in Bahria International Hospital from 2016 to 2018. We have enrolled 115 post-renal transplant patients. You can see the majority of the study cohort was male gender. 101 were males and 14 were females, and they were enrolled from April 2016 to April 2018, and obviously they were previously non-diabetic patients. And the patients who were excluded from the study were those who were having pre-existing diabetes and the follow-up duration of less than 12 months. So we have given these renal transplant patients the standard immunosuppressant according to the protocol of our center, IV methylprednisolone, followed by oral steroids 1 milligram kg per day with obviously progressive tapering down, and a maintenance regime comprised of prednisolone, mycophenolate, mofetil, and calcineurin inhibitors. We have defined new onset diabetes after transplant according to American Diabetes Association criteria with a fasting plasma glucose of more than 120 milligram per deciliter, or random plasma glucose levels of more than 200, along with the symptoms of weakness or weight loss, polyuria, or diabetic emergencies. You can see the majority of patients presented to us with weakness, whereas some of the patients presented to the combination of weakness and weight loss, but diabetic emergency was not a usual presentation amongst our study cohort. We have treated these patients with dietary lifestyle modifications, oral hypoglycemic agents, and insulin. Majority of the patients were treated with the combination of oral hypoglycemic agents along with insulin. They were 39%. So this table shows the results of time duration for the onset of diabetes. You can see the majority of patients develop no DAT in first 6 months of transplant. You can see that 6 patients develop diabetes within first 2 months, whereas next 6 patients develop diabetes in up to 4 months, and 7 patients develop diabetes from 4 to 6 months. So the incidence was a bit higher in first 6 months. This table shows the comparison of various risk factors between NODAT and NODAT group. We have compared different risk factors, but you can see the family history of diabetes and number of HLA mismatches and infections like hepatitis C and CMV were the strong risk factors. We have used tacrolimus more in the patients as compared to cyclosporins, but that effect was not significant in our study. So the incidence of no DAT in first year of transplant in non-diabetic kidney transplant patients have been reported as 7 to 3% in the past studies. As compared to our study, the incidence was found to be 24%. So incidence is usually more during first 6 months of renal transplant, and it is well explained because the higher dose of immunosuppression and patient is heavily immunosuppressed during this period of time. So we concluded that the incidence of new onset diabetes after transplant was 24.3% in our study, whereas the pre-transplant fasting plasma glucose level, family history of diabetes, and increased HLA mismatches and infections like hepatitis C and cytomegalovirus infections were the major risk factors. Of course, there were certain limitations with our study. It was a single-center experience. We have not evaluated the effect of drug levels on the development of post-transplant diabetes. Although oral hypoglycemia, oral glucose tolerance test is a gold standard test for the diagnosis of no DAT, but we could not use this as a screening test. This can lead to the underestimation of incidence in our study cohort. Coming to the reference study, what we have gone through the literature so far, the majority of studies have evaluated the risk factors for the development of post-transplant diabetes, and so as our study. This study was done in Turkey, and the authors have concluded the incidence of new onset diabetes after transplant and have evaluated different risk factors. The similar results have been shown in this study. Family history of diabetes, pre-transplant lipid levels, and age were the significant risk factors. This was a Portuguese study. It was a retrospective study, new onset diabetes after transplant, and they have also evaluated different risk factors for the development of no DAT. In this study, family history, more age at the time of diagnosis, and pre-transplant fasting plasma glucose levels were the strong risk factors. So this was a study. We can see from this slide that age more than 45 years and body mass index more than 30 kilogram per meter square were the strong risk factors. So coming to the topic, it is a serious condition with a significant mortality and morbidity. Regarding the pathogenic mechanism involved for no DAT, there are some pre-transplant mechanism and post-transplant factors. Pre-transplant mechanism includes genetic variability leading to increased insulin resistant and decreased insulin sensitivity, ultimately leading to impaired glucose tolerance, and no DAT is developed. Pre-transplant factors include old age, family history of diabetes, African American race, and obesity, whereas post-transplant factors include, obviously, immunosuppressive drugs have a role. Tacrolimus is more diabetogenic as compared to cyclosporin. Non-modifiable risk factors I've already explained, whereas modifiable risk factors included immunosuppressive therapy and infections like hepatitis C and CMV. The risk of no DAT in first year is 15 to 30%, but after 1 year, the risk of no DAT is similar to that in general population. So I've already discussed about the diagnosis. Management is same as that of general population. Thank you so much.
Thank you. Thank you very much. The next paper has been readjusted as Dr. Aziz Aftab has just arrived. He will present a paper on outcomes of tunnel cuffed catheter for hemodialysis. He's from AKUH Karachi. Dr. Aziz Aftab. Number 2 onwards से ये हो गया है, ये वाला हो गया है, ये हो गया है, ये वेरी
Assalamu alaikum and good morning, everyone. The topic of my research presentation is the outcomes of tunnel cuff catheters, and the study was carried out in Tertiary Care Hospital. And my name is Dr. Azib, and I'm from the Akhan Hospital. So, as you all know, that the life of a tunnel cuff catheter is variable, and it's ranging from 9% at 1 year to 89%, 77%, and 64% at 60, 90, and 180 days post-insertion. Catheter dysfunction severe enough to cause catheter displacement has been reported as around 16% per year. Systemic bloodstream infections with local site infections are associated with tunnel cuff catheters. The average risk varies between somewhere around 20 to 25% over the duration of use. Streptococcal and staphylococcal infection remains the major causes. So the rationale of our study was to determine the outcome of tunnel cuff catheters at a hospital, also to identify the magnitude of potential complications and hence to develop a strategy to avoid them. And along with that, also the local data that was available is very scarce, and most of the data that has actually available is from radiology, but not from any nephrology or any vascular surgery. So the study design that we followed was a retrospective observational study. The setting was the hemodialysis unit in the Akhan University Hospital. The data was collected from January 2016 till July 2018. The inclusion criteria actually had included all those patients who had their tunnel cuff catheters inserted in the Akhan hospital and were more than 18 years of age and were getting dialyzed in our hospital only. The exclusion criteria was again a patient having an age of less than 18, and if that patient even had a single hemodialysis session outside AKU, that patient was excluded. So the results, as we can see, as per the age criteria, most of our patients are more than 60 years of age. Okay, majority of the catheters, that is more than 50%, around 55% of our catheters were inserted in the right internal jugular. And the major reason for catheter removal was actually the maturation of AV fistula, closely followed by infections as well. So one of the major complications due to which the catheters were actually removed, and the complication was the CRBSI, that is the catheter-related bloodstream infection, and the most common organism that we found was MRSA, followed by fungal infections. So the mean age of the population was 57.09 years, and 58.6% of them were males. The right internal jugular was the preferred access, followed by the left internal jugular vein. Majority of the catheters were removed on successful maturation of the AV fistula, whereas 22.4% were removed due to the infections. 5.17% of the patients had catheter malfunction. The most common organism that was isolated was MRSA, followed by fungal infection, predominantly Candida, which was 26%. CRBSI was identified as the most frequent complication leading to catheter removal, having a significant p-value of less than 0.001. CRBSI was significantly identified within the first 45 days as well, having a significant p-value. So a conclusion was that 2/3 of our tunnel cuff catheters were removed without any complications on successful maturation of the AV fistula or the AVBG. The safety and longevity of tunnel cuff catheters make them an excellent choice for hemodialysis access only while we are waiting for the maturation of our AV fistula as a permanent access. These are the references. Thank you. If there are any questions, I would be more than happy to answer.
At the end of the session.
Okay. Thank you.
Now I call from the Jinnah Medical and Dental College, Karachi, Dr. Majibin Yasmin. She will present the free paper on the UTI in pregnant female attending the antenatal clinics among middle socioeconomic settings. Dr. Majibin, is she here? No. Go on. Is Sonia Asif is here? Okay, I will request Dr. Sonia. She will talk on the can a simple MCV denote iron deficiency in end-stage renal disease patient. She belongs to Bahria Hospital, Lahore.
Thank you, sir. Assalamu alaikum. My name is Sonia Asif and I am from Bahria International Hospital, Lahore. And the topic of my study is, can a simple MCV represents iron deficiency in end-stage renal disease patients? As all you know that MCV is a measure of average volume of RBCs and its reference range is 80 to 100 femtoliters per cell. And low MCV indicates smaller than average size of RBCs. The most common cause of low MCV is iron deficiency, which may be due to malnutrition, gastrointestinal bleed, excessive menstrual bleed, thalassemia, and sideroblastic anemia. Iron deficiency is very common in end-stage renal disease patients, and it is investigated on monthly basis through serum transferrin saturation and complete blood count, which includes MCV. Whether a simple MCV can replace TSATs has not been studied extensively in end-stage renal disease patients. So the objective of the study was to conducted to ascertain whether a relationship exists between MCV and TSAT in end-stage renal disease patients. This is a cross-sectional study, and the study was carried out in hemodialysis unit of Bahria International Hospital, Lahore. A total of 96 ESRD patients on MHD were included in the study, and their MCV and TSATs of each patient was noted. We categorized the patients in those with normal or high MCV and low MCV and matched them with their respective TSATs. And the collected data was entered into the SPSS. Subsequently, the Comparator correlation coefficient was used to ascertain the relationship between MCV and TSAT. 76% of the participants had transferrin saturation greater than 20%. Amongst these, 81% had MCV greater than 75%. On the other hand, 61% of the participants had TSAT less than 20%. Amongst these, 19% of the participants had MCV less than 75%. And the Comparator correlation coefficient was 0.36. As shown in the figure, 61% of the participants had TSAT 20%. Amongst these, 19% of the participants had MCV less than 75%. On the other side, 76% of the participants had TSAT greater than 20%. Amongst these, 81% of the participants had MCV greater than 75%. This means that both variables, they move in same direction, and that shows that there is a positive correlation between MCV and TSAT. If one variable increases, the other one also increases. That shows that there is a positive correlation between MCV and TSAT. So the conclusion of my study is there is a positive correlation between MCV and TSAT. More studies are needed to ascertain whether MCV can replace TSAT in end-stage renal disease patients. Thank you.
Okay, now on move to the another paper from the Dow University of Health Science. Dr. Mohammad Tasadduq Khan, is he available here? No. Okay. Dr. Zahideen, I will request Dr. Zahideen from the KRL hospital. He will talk on the C4D negative antibody mediated rejection.
Bismillahirrahmanirrahim. My name is Dr. Zahidul Zahideen and I'm a final year resident in Care Hospital, Islamabad. I belong to a small hospital, 300 bedded hospital, and we are having a transplant patient pool of around about 160 transplant patients. And we came across this unique case of C4D negative, DSA negative antibody mediated rejection. My patient, 31 years old gentleman, known case of end-stage renal disease, secondary to underlying chronic glomerulonephritis, underwent blood group compatible living related renal transplant, and the donor was paternal uncle, 47 years old, mismatched at 4 out of 6 antigen, and historical pre-transplant cross matches like CDC, Luminex, and flow cytometric cross match were negative. Induction was given with basiliximabs and steroids. Maintenance immunosuppression included prednisolone, tacrolimus, and MMF. His surgery went uneventful, had urine output of around about 500 to 600 ml per hour post-operatively for first 24 hours. Had improvement in serum creatinine, had improvement in creatinine to 2.6 on first post-op day from the post-hemodialysis creatinine of 5.3. As my patient was performing well, he was hemodynamically stable, you see that the urine output on second post-op day dropped to 3 liters, and on third post-op day to merely 1.2 liters, and the rise in creatinine was from 2.6 to 3.7 and to 5.2 on fourth post-op day. So we performed ultrasound Doppler of the grafted kidney that was normal except for the raised renal indices, and urinalysis showed 1+ protein and 4 to 6 RBCs. Allograft biopsy was performed that showed 30% peritubular capillaritis and glomerulitis in 4 out of 8 glomes with negative C4D by immunofluorescence method. There was no tubulitis, no arterial hyalinosis, or no isometric vacuolization. Repeated CDC cross-match and DSA detection by Luminex single antigen bead assay came back negative. Actually, we are having a liaison with Brigadier Tahir, who's a senior immunologist in Shifa International Hospital, and he told us that we have seen such cases in which the biopsy findings were of AMR and single antigen bead assay is negative. The repeat sample was also sent to AFIP and it came back negative. We also thought of non-HLA antibodies, but unfortunately the assays, the radio assays, ELISA assays are currently not available in Pakistan. So the patient was managed on the lines of AMR, tacrolimus dose was adjusted, 6 sessions of IVIG and plasma exchange on alternate days resulted in gradual improvement. Patient was discharged on 17th post-op day with the creatinine of 1.7 with blood urinalysis. His RFTs on follow-up after 3 days were normal with the creatinine of 1.1 and remained normal ever since. Now coming towards the literature review, many studies have been published in the past about this issue. This study published in Lancet in 2005, and they found the presence of increased PRA in HLA identical siblings. And the cause of increased PRA, they showed that it was probably the presence of non-HLA antibodies. Since 2005, many articles have been published explaining the role of endothelial cells in antibody-mediated rejection. Endothelial cells like HLA antigens, non-HLA antigens, MYC antigens, they have explained that they might be associated with AMR. Non-HLA antigen targets include angiotensin II type 1 receptors, endothelial type E receptors, vimentin, and addition molecules like ICAM4. Then this case report published in Nephrodial Transplant in 2010, and they found AMR in a patient of HLA identical sibling. Again, the biopsy findings were of AMR, and DSA and C4D were negative. They managed this patient on the lines of AMR with Plex and IVIG and found a good response. Again, this paper published in Kidney International in 2011, and they found that non-HLA antibodies are associated with AMR. Then came the BAMF 2013 meeting report. Enough evidence was already there which forced the participants of BAMF 2013 to include C4D negative rejection in AMR, and the revised criteria is as shown below. So this point, if you're having at least moderate microvascular inflammation, glomerulitis plus peritubular capillaritis greater than or equal to 2, then this 1 and 2 criteria are fulfilled. And you only need the serological evidence for DSAs like HLA or other antigens. Unfortunately, to detect other antigens, the radioimmunoassay, they are not available in Pakistan. Then this study published in the 2017 American Congress, and they found the incidence of donor-specific negative AMR is 13.1%, and 7.5% are C4D negative. Again, this article published in Transplant International in 2018, and they found that the outcome of DSA negative and DSA positive transplants are same. What's new about AMR? Coming towards the BANF 2017 meeting report, they included that if you are not finding DSAs for HLA or non-HLA antigens, then you can include this criteria that C4D staining or expression of validated gene transcripts and classifiers in renal biopsy. But again, the validated genes and validated transcripts in renal biopsy are not currently available in Pakistan. The proposed list of genes was this one by many studies. So rational treatment decisions based on histopathological criteria and clinical correlation are still invaluable for the management of AMR in few challenging scenarios. Biopsies with histological AMR but without detectable HLA present rare and distinct scenarios with heterologically reported allograft survival so far. Thank you.
Thank you, Dr. Zahidin. Now I will request Dr. Mohammad Rizwan from the Liaquat National Hospital, Karachi. His talk on the role of cholecalciferol in the management of secondary hyperparathyroidism. Dr. Mohammad Rizwan.
Assalamu alaikum everyone. My name is Dr. Rizwan, and I will be representing my department from Liaquat National Hospital, Karachi. The topic of our free paper presentation is the role of native vitamin D, which is cholecalciferol, in the management of secondary hyperparathyroidism in dialysis patients. Vitamin D has been one of the vitamin D is known to be one of the fat-soluble vitamins that has always been considered as a precursor of endocrine agent regulating calcium and bone mineral metabolism until the end of 20th century. However, the past decade we have seen the data showing that vitamin D has autocrine action as well as paracrine action. So this is just for a review, the vitamin D metabolism, in which we can see that we have a 7-dehydrocholesterol, which is converted into cholecalciferol, and then we have ergocalciferol and cholecalciferol from plant and animal origin, which converts in liver by hydroxylation to 25-hydroxycholecalciferol, and then another hydroxylation occurs in kidneys, which converts that into 125-hydroxycholecalciferol. Now, there have been many tissues like pancreas, colon, skin, breast, prostate, cerebellum, macrophages or cells of vasculature that not only express vitamin D receptors but also possess 1-alpha hydroxylase and are therefore capable of production of 125-dihydroxycholecalciferol, which may act locally. This may indicate an autocrine and paracrine function of this enzyme in the control of cell proliferation and differentiation. So vitamin D and kidneys, patients with CKD5 are at high risk for deficiency in the storage form of vitamin D due to a variety of factors, including poor dietary intake, reduced sunlight exposure, and decreased skin synthesis of pre-vitamin. They are also deficient in renal activated form of vitamin D, that is 125-dihydroxycholecalciferol. In secondary hyperparathyroidism, the loss of kidney activated 125-dihydroxycholecalciferol is mainly responsible for negative endocrine effects on bone and mineral metabolism, leading to secondary hyperparathyroidism. Traditionally, secondary hyperparathyroidism has been treated with active vitamin D analogs like calcitriols or calcidiols mainly because of decreased activation of vitamin D in the end stage kidneys. The role of native vitamin D in the dialysis patients has always been questioned. In the recent years, studies have been done showing decreased stores of native vitamin D in dialysis population, repletion of which in the form of native vitamin D led to improved cardiac function, decreased inflammation with improved immunity and hematocrit levels. So, in KDIGO guidelines, they recommend the use of native vitamin D in early stages of CKD, which is 3 and 4, and they have written it that they have used ergocholecalciferol, which is not available in our country. But they do not recommend the native vitamin D supplementation for supposed lack of 1-alpha hydroxylase, that is in the patients with ESRD, CKD stage 5. So keeping these both these effects that vitamin D has autocrine and paracrine action, as well as that we can keeping in mind that we can also use native vitamin D in CKD stage 5, we did a pilot study to evaluate the role of cholecalciferol in the management of secondary hyperparathyroidism in hemodialysis patients with vitamin D deficiency or insufficiency. So we had a total of 42 patients that were on maintenance hemodialysis. All patients included in the study had serum PTH of more than 300 and vitamin D levels of less than 30. Patients were followed for 3 months. This was a study designed for 6 months, but we found beneficial effects of cholecalciferol just within 3 months. So we hold our study at 3 months. Patients with vitamin D levels less than 15 were labeled as vitamin D deficient, and they were treated with vitamin D 600,000 international unit intramuscular monthly for 3 months. And the vitamin D levels of more than 15 and 30 were treated with 200,000 international units IM monthly for 3 months. And PTH, vitamin D, and calcium phosphorus levels were monitored. Inclusion criteria included maintenance dialysis patients for more than 6 months, age of 18 to 70. Exclusion criteria, corrected calcium of more than 10, and phosphorus of more than 5.8, hyperparathyroidism of more than 800, calciphylaxis and liver disease. All these patients were excluded. So this is the data in which we can see the mean age of 55 of our patients that were included, out of which 16 were males and 26 were female. In this data, we can see that at pre-treatment, our PTH was 591.5, which had significantly declined at 317.8. And vitamin D levels increased from 10.4 to 33.3, which were also significant. So we had divided our patients into 2 groups, vitamin D deficient and vitamin D insufficient. In the group that was vitamin D deficient, PTH levels significantly improved and they were declined, and vitamin D levels increased significantly. In the second group, we can see that that was vitamin D insufficient. PTH levels did not decline that significantly, but vitamin D levels had improved. So in the results, all the patients had PTH levels of more than 300, and we can see that PTH levels were declined significantly, and vitamin D levels improved and increased significantly as well. The results were more remarkable in patients with vitamin D deficiency as compared to patients with vitamin D insufficiency, which we already told. There was no significant change in calcium and phosphorus levels. So in this line graph, we can see the PTH levels. The red one indicates the pre-treatment PTH levels, and the blue line indicates the post-treatment PTH levels. And we can see that there's a significant decline in that. This is the chart that shows vitamin D levels. So in conclusion, we can use cholecalciferol in ESRD patients. These are the references. Thank you.
Okay, thank you, Dr. Mohammad Rizwan. Now I request Dr. Mudassar He belongs to Shaukat Khanam Hospital. He will talk on the prevalence of non-diabetic renal disease in type 2 diabetes.
Thank you very much and good morning. So this is a study that we conducted in the Shaukat Khanam Hospital in the biopsies which were sent for in the patient who have the diabetes and for the diabetic nephropathy in order to see what are the different kinds of non-diabetic renal diseases are present. So this is a prevalent disease all over the world. So in the area where we are living, its prevalence is 75 million people. So, clinically, and I think that you are the best person to judge what are the clinical features in the patients of diabetic nephropathy, such as albuminuria, deranged renal functions, reduced GFR, hypertension, and mortality and morbidity is also increased by cardiovascular complications. One of the most common cause of end-stage renal disease around the globe, and there are a number of researches from Japan, Europe, and USA which have reported 25% to 45% diabetes enrolled in the end-stage renal disease. It's definitely a leading cause of death. Survival rate is dependent on associated secondary pathologies. So what is the study rationale? The diagnosis of diabetic nephropathy is almost and always based on clinical grounds and is supported by a long history of diabetes, evidence of target organ damage, and proteinuria, which is preceding azotemia. Diabetic nephropathy is not the only disease in the diabetic patients. Many non-diabetic renal diseases have been uncovered by renal pathologists and in the renal biopsies. So in the worldwide, different studies have been reported a variable prevalence of non-diabetic renal disease in the different populations. In India alone, the prevalence of non-diabetic renal disease in diabetic patients have been reported from 13 to 75% in different studies. Only one study has been conducted so far in Pakistan for non-diabetic renal diseases, and this study will help highlight the importance of renal biopsies in the clinical settings to timely diagnose non-diabetic renal diseases for possible intervention. So what are the objectives? Prevalence and the different types of non-diabetic renal diseases in the renal biopsies at SKMCH and RC, which are tested during last 4 years. Methodology: we got the patients who have the history of more than 1 year of diabetes and presented in our hospital as the biopsies from January 1st, 2016 to June 30th, 2019. The first thing is to make the formalin fixed tissue. The thickness is 3 microns stained with H&E. In addition, we used different other stains, special stains, such as silver stain, which is GMS, PES stain, trichrome, to view the light microscopy. In addition, we correlated all these biopsies with the immunofluorescence, IgA, IgG, C1q, C3, and IgM. This should be IgM. Okay, and what is the study's design? Cross-sectional retrospective study conducted at SKMCH and RC. There are 3 groups. The first group in the patient which have diabetic nephropathy, the second non-diabetic renal disease, and the third one is the diabetic nephropathy with the non-diabetic renal disease. This is the diabetic nephropathy classification of 2010. The first one is the class 1, which is can only be diagnosed on the basis of EM. This is the class 2. There is mild mesangial expansion. Class 3, marked mesangial expansion. This is the this is the class 2B, and this is the class 3, which the KW nodules. They are the hyalinized lesions, and this is the class 4 when there are more than 50% sclerotic glomeruli. So what are the different kinds of non-diabetic renal diseases we identified in our biopsies? Number 1 is the AIN, then post-infectious GN, membranous nephropathy, crescentic GN, minimal chain disease, focal and segmental glomerulosclerosis, IgA nephropathy, amyloidosis, and lupus nephritis. Minimal chain disease can only be diagnosed on the basis of EM, but when there is a strong history of nephrotic gain protein, urea, and the biopsy is completely normal, we can suggest that this is a minimal chain disease. And the last one is the membranoproliferative GN. So what are the different morphologies? This is the IgA. There is segmental sclerosis, but the IgA is positive, so this is IgA nephropathy. 25 seconds left. So this is the focal segmental glomerulosclerosis. Sclerotic area is present here with the adherent to the Bowman's capsule. Amyloidosis, and then the lupus nephritis. This is the crescentic GN. These are the crescentic areas. And the membranoproliferative glomerulonephritis. And these are the references which almost studied in the same way, and this conclusion is the same. Thank you very much.
Thank you, Dr. Mudassir, for nice talk. Now I'll request Dr. Fazl Mohammed. He will talk on the frequency of thrombotic microangiopathy in patients with pregnancy-related acute kidney injury.
Bismillah ar-Rahman ar-Rahim. Good morning, everybody. The study which I have done, that was of the frequency of the microangiopathy in a patient with acute kidney injury during the pregnancy. Pregnancy-induced acute kidney injury is considered to be the entity of the heterogeneous disease which happened due to the large number of the etiologies. The thrombotic microangiopathy is defined as the presence of the fibrin, platelets, thrombi in the arterioles and capillaries of the vital organs, just as brain and kidneys. During the pregnancy and postpartum, with a low number of the platelets, usually less than 50,000, with evidence of the hemolysis by MAHA, and raised LDH and indirect bilirubin, sometimes neurological symptom as well in the shape of the fits. TTP usually presents in the second and third trimester, as the NUH was most probably present in postpartum period. TTP is caused by the deficiency of the ADAMTS13 deficiency. ADAMTS13 is mandatory to cleave with the von Willebrand factor. The lack of the ADAMTS13, which is either acquired or inherited, result in accumulation of the ultra-large von Willebrand factors leading to the platelets aggregation and thrombosis and microvessels. Von Willebrand factor levels increases during the pregnancy, returning to back within 6 weeks postpartum. Von Willebrand factor and ADAMTS13 have reciprocal relationship with each other during the pregnancy. In second and third trimester of the normal pregnancy, ADAMTS13 activity usually decreases, both because of the excessive substrate of the von Willebrand factor and estrogen effects. This is the reason that the TTP is most commonly seen during the pregnancy. While in HUS there is a mutation in the complement pathway, alternate complement pathways such as the CD46 and factor H, factor I, factor B, and C3 complement pathway. TMA presents with the swelling of the endothelial cells, subendothelial accumulation of the proteins, and cell debris, in certain cases leading to the splitting of the glomerular basement membrane. In the medical practice, it becomes sometimes hard to distinguish clinically between the TTP, HUS, eclampsia, preeclampsia, and HELP syndrome. The TTP will be diagnosed with these features, presents with a severe thrombocytopenia, with a high level of the LDH. Patient usually present with second and third trimester of the pregnancy. with less severe renal failure and failure of the resolution of the thrombocytopenia 3 days after the delivery. ADMTS13 level will be less than 10%. In HUS, it is more severe renal failure with postpartum presentation. ADMTS13 level will be more than 10%. The mutation of the factor involved in the alternate pathway will be present over there, and the presence of the hematological abnormalities as well as renal dysfunction will be dysfunction after the delivery will be seen. The failure of the resolution of the renal failure with plasmapheresis. In this study, we would determine the frequency of the thrombotic microangiopathy in a pregnancy patients with acute kidney injury. Study material method. The study design, it was a cross-section study, was done in the Department of the Nephrology, Bulistan Institute of Nephrology, with the collaboration of the Obs and Gynae Department, Bolan Medical College Hospital. The study duration was from July 2016 to December 2017. This was a convenient sampling method. The inclusion criteria comprises all patients with the evidence of the AKI, MAHA, thrombocytopenia, raised LDH, normal coagulation profile, neurological abnormalities without any other apparent cause like HELP syndrome, EPLA, or preeclampsia, eclampsia that was ruled out. Biochemical analysis of the ADMTS13 was done during this study. The ethical committee approval was taken, and data collection pro forma was designed for the proper history, age, complete physical examination, laboratory investigations, and data was analyzed by SPSS version 22. For continuous variables, age, the mean standard deviation was taken. For qualitative variables, chi-square test was applied. The results. In this study, total population of the study, that was 2,763, was taken from the gynae department. In these patients, 221 patients developed acute kidney injury. That was 8% of total population, which was included in the study. Among 26 patients, the pregnancy-related thrombocytopenia was seen, who was leading to the acute kidney injury. The mean age of the patient, that was 29.5 plus minus 3.8 years. In these total 26 female patients, 15 were nulliparous and 11 were multiparous in the study. With respect to the thrombocytopenia microangiopathy, 19 patients were found to have a TTP, as the 7% was diagnosed as having the HUS, which constitutes 73 and 26 respectively. The 80% of the patient presented with the TTP in the second and third trimester, while 20% patient postpartum in the HUS, 100% for patient was seen after the delivery. In this study, the patient with the initial dialysis, in the TTP, 50% of patients required hemodialysis initially, and there was 10% was dialysis dependent. In HUS, 90% required dialysis in the start, 80% was dialysis dependent. If we see the laboratories value, the p-value significant of the platelets, that is 0.03, which was low, and creatinine is 0.04, other was non-significant. In discussion, the different studies which was done in previous with literature review, all of the studies shows that the acute kidney injury values was almost the same, and the multigravida and the mean primary gravida and the mean age, this was almost in all same in the all studies. Percentage of the TMA in the AKI, it was almost same in the all studies which I have quoted. HUS and TTP population percentage was same in all studies. In the progress of the disease, either patient needs dialysis or it was dialysis dependent. It was a bit different because due to some limitations of the study, because the study which was quoted or which was in the literature review, their results were better than this study. That was only due to the early start of the plasmapheresis and with the treatment of the eculizumab. The eculizumab was, in their studies, they have started the eculizumab. As far as in our study, we didn't use the eculizumab because it was not available in our centers. Thank you very much.
Now we have completed the session. Is there any question and answer you can ask from the speakers?
Any questions? Okay. I would like to make an announcement that please download the PSN app because all the voting will be done between 9:30 to 10:30. So please download the app. I would request Dr. Professor Tahir Shafi Saab to please present the shields to our chairs and co-chairs. Please, sir, Professor Mohammed Usmani Saab, aap come to this. Sir. Professor M.H. Usmani, please receive your seat, sir. Professor Abdul Manan Junejo, please, sir, receive your shield. And Associate Professor Muhammad Abid, please. Okay. And now, please. Okay. Thank you. Okay, ji, thank you. This is the end of our session. Okay.
So let's start with the next session. Where is Dr. Farooq? Kindly come. कौन नहीं आए?
Good morning. My name is Dr. Farooq. I am Registrar Nephrology in Pakistan Kidney and Liver Institute, Lahore. And we will start our next session. For this session, I will like to invite Dr. Fazal Akhtar. Sir, please, if you can chair the session. And for the co-chair, I would like to invite Professor of Nephrology, Dr. Salman Tahir Shafi. He is from Sharif Medical City, Lahore.
morning, ladies and gentlemen. Assalamu alaikum. It's an honor for me to invite Frederick Finkelstein, who is the head of the Nephrology division in the Yale University, and he is the president of the International Society of Peritoneal Dialysis.
Plenary session, day three, this one, and plenary session.
Yes.
Yeah, that's it.
Thank you very much, and thanks you all for coming after this wonderful evening last night. We got back about a little after 1 in the morning, so thank you all very much for getting up this early to come to the lecture. It's really been a pleasure and honor for me to participate in this really excellent conference. My wife and I have spent the last week in Pakistan and Islamabad, Muzaffarabad, and here, and it's indeed been a pleasure for us to enjoy this wonderful country, the hospitality of the people, and the beauty of the scenery. So I'm going to talk this morning about a global perspective of peritoneal dialysis and try to relate this to development and growth of peritoneal dialysis in Pakistan. What's made it complicated now in terms of treating end-stage kidney disease, that there's a lot of treatments which are really available. If I were giving this talk 15 years ago, I would have said there's peritoneal dialysis, hemodialysis, and transplantation. But there are multiple options for hemodialysis, which are shown in red on this slide. And there are 3 ways of doing PD, either CAPD, automated PD, and hybrid dialysis, which is combining PD with HD, which is practiced routinely in Japan, and is actually utilized in other countries. We actually have 2 or 3 patients on hybrid dialysis. And obviously transplantation and conservative care, which was discussed at length yesterday in the sessions. But how we integrate these different treatment options in this world of patient-centered care and shared decision-making, which are the new buzzwords in healthcare delivery and healthcare reform, where you focus on the individual patients, their concerns and values and goals. And the question we need to ask ourselves is, how does this fit with government decision-making concerning end-stage kidney disease care and government reimbursement policies, which are crucial for the expansion of end-stage kidney disease services? So end-stage kidney disease, and I'm talking about this later on this morning, there was a summit meeting held in Sharjah in UAE in 2018, and the summary of this meeting was just published in Kidney International this year. The key recommendation of this, one of the key recommendations, is that PD be expanded for both end-stage kidney disease and acute kidney injury care, particularly in lower resource regions. And the reason for this is the costs are easy. Technically, it's very simple. And treatments have really gotten much better for this, as I'll show you in a few minutes. It's interesting that Donald Trump would like 80% of US patients with end-stage kidney disease on home therapy or transplanted. Is that goal really achievable? The answer is no, as most things that Trump says. But on the other hand, it has raised the awareness of home therapies for patients, and I think it's important for us to think about that. So what's happening globally with peritoneal dialysis? There's a remarkable variation in home dialysis and PD utilization. But to put that in the right context, I want to show you what the incident rates for treated end-stage kidneys are per million population taken from the US RDS in 2018. And again, this reflects data that's in 2016. So I'm going to show you a slide in a minute that shows how PD and HD vary around the globe, but it has to be put in the right context. So one thing that we discussed in the meeting in Sharjah is, how do you explain this tremendous variation in end-stage kidney disease around the world? The highest rates are in Taiwan and Japan. The incident rates, that is the treated rates of patients with end-stage kidney disease, get lower and lower. I don't believe Pakistan is not on this slide. I don't believe Pakistan has a registry for end-stage kidney disease. But Bangladesh, for example, is running at 51 per million per year. So when we look at the way home therapies are segregated, we need to look at this. Now I'm going to talk more about the varying rates of end-stage kidney disease in my talk later on this morning when I discuss the End-Stage Kidney Disease Summit that was held in UAE. So this shows the percent distribution of prevalent dialysis patients by modality, where the blue is the hemodialysis, The orange is peritoneal dialysis, and the yellowish color is home hemodialysis, which accounts for a very small percentage of patients on home therapies. But again, you see this tremendous variation. You have countries like Japan, which is really up at the very top, that has about 3% of its patients on home dialysis. The US has about 10 or 11% on PD therapy now. Countries in the UK, Australia, Netherlands, Canada, for example, are running about between 20 and 25%. And you can get up to numbers where 80% are on PD therapy in countries like Hong Kong. And I wanted to sort of review for you what the differences are in these countries. So let's start with Hong Kong and Thailand. Hong Kong started a PD First program many years ago, and that was that the government would only pay for treatments for end-stage kidney disease if patients went on PD, unless there was an absolute contraindication for PD therapy. In this model, 80% of patients with end-stage kidney disease are maintained on peritoneal dialysis. And patients in Hong Kong understand that the costs need to be contained to protect the low tax structure and universal health coverage that's present in Hong Kong. So PD in Hong Kong is much cheaper than it is for hemodialysis, and I'll come back to this in just a minute. Thailand started a PD First policy about 5 or 6 years ago, and what's interesting about that, if you look at the slides on the right-hand side, the top is patient survival, the bottom is technique survival. The dotted line is what's happened since they started the PD First policy. The bottom line is what happened prior to starting the PD First policy. So people thought when they introduced the PD First policy, technique survival rates, patient survival rates would decline because they'd be putting patients on PD who were not optimal candidates. But the reverse was true. Actually, results got better, as did peritonitis rates. The example suggesting really that as you get more experience with PD therapy, outcomes really improve because you understand how to deal with the complications that arise. And that's something that's held up everywhere in the world when this is looked at, that the more patients you have on the therapy, the better the outcomes become. So Thailand is a very interesting lesson for lower resource countries to look at when deciding how end-stage kidney disease therapy ought to be developed. So Mexico is an example where, and this is the state of Jalisco is the primary state in Mexico that has the best data, suggesting that available resources drive practice patterns, that PD utilization in this state had been at 90% because of almost no hemodialysis facilities. Now the government was paying for end-stage kidney disease care, but they put 90% of patients on PD. Now, Jalisco is south of Mexico City. It's a very poor province, very poor state. So the patients are very poor. This is not a well-developed country, high-income country. It's a low-income country. And the results really from Mexico have always been very good. But when the government allowed private companies to come in and build hemodialysis units, hemo units expanded and PD utilization dropped, and it's now running about 50%. But importantly, the cost of PD is very low in Mexico. There's a Mexican company that makes PD solution, and the government does the contracting. So for the PD supplies, and this gives an example of what I call the power of the single purchaser. That if the government decides they're going to purchase supplies for the entire state, for the entire country, for example, they can negotiate significant discounts in pricing and keep the cost of treatment very low. So this is a very good example also for low-resource countries of the way of thinking of coordinating care, coordinating purchasing as a way of reducing costs. In the United States, as with most things, finances drive practice patterns, unfortunately. That's what happens in a capitalist society, I guess. But the government and private insurance pays for all care, but 90% of dialysis is provided by for-profit companies who build dialysis units and hemodialysis units and work to keep the chairs filled with patients to maximize revenue. So that has always kept the cost of percentage of patients on PD extremely low, and traditionally was running about 7% in the United States. But in 2010, the government introduced a bundled payment system, which was they paid a flat fee for dialysis, which included all medications, ESAs, for example, intravenous iron, vitamin D supplementation, etc. In that model, though, the cost of PD becomes much less, and PD becomes far more profitable. So this shows what's happening to the incident and prevalent patients on home dialysis, which is primarily PD. And in 2010, when the bundled payment system goes into effect, lo and behold, the numbers start to rise. And the numbers on PD therapy are rising in the US. They're up to about 11 or 12% now. and most people think it's going to level off somewhere around 15% or so. But again, this is an example of finances driving practice patterns. If you made the finances in favor of PD therapy will grow. But in Europe, Canada, and Australia, it's a more equitable system in many ways, and patient education really drives practice patterns. So as I showed you, there's a reduced access to end-stage kidney disease care because the incident numbers I showed you, remember, were much higher in the US than they were in Canada, Australia, or most European countries. But the government provides equitable supportive health care. Care is much better organized. All these countries have CKD clinics, low-clearing clinics for people with GFRs less than 20. They have palliative care. They have a patient-centered care approach and an emphasis on patient education. And in this model, 18 to 25% of patients wind up on home therapy, primarily on peritoneal dialysis. So this is an example of what happens. This is data from, it's old data, but the same data holds up today, from the Netherlands and published in 2004, where patients were given choices about therapy. And in this model, 38% of incident patients with end-stage kidney disease starting dialysis started on peritoneal dialysis. And this model is held up in other countries as well. So if patients are given a free choice, provided the proper education, 38% would start on peritoneal dialysis. But Canada is an interesting example, and primarily I'm going to focus on the province of Ontario. This is where Dimitri Oriopoulos first started CAPD in 1978. That's where the treatment actually originated. Peter Blake is now in charge of nephrology throughout the province of Ontario. They have a nephrologist who coordinates all of nephrology care throughout the province. They've had a tremendous effort to grow home therapies, and Oriopoulos, as well as Peter Blake, have set targets of having 30% of patients on home therapies. But despite this tremendous effort, they're now running these numbers here: 75% on hemodialysis, 5% on home hemodialysis, and 20% on peritoneal dialysis. And these numbers have really leveled off now. They're not increasing anymore. In fact, they started to drop slightly. So to my mind, this number is probably a very appropriate number and a reasonable expectation that if you really make an effort to grow PD and allow patients to make decisions without forcing them onto PD because of financial incentives, you can probably get 25% of your patients on home therapy and the vast majority of these on peritoneal dialysis. So what about the costs? I mean, should PD, I'd mentioned that PD is cheaper, and how much cheaper is it? So again, what's important about this is you have to think of this in a holistic view. It's not simply the cost of dialysis, it's the complete cost of caring for patients. So this is from the USRDS database, and it shows that if you look at the cost for caring for patients, take into account medication, hospitalizations, transportation to dialysis facilities, et cetera, dialysis only accounts for about 40% of the total cost of caring for these patients. And in this model, PD is significantly less costly than hemodialysis. In the US, it's $16,000 per year cheaper than hemodialysis. This is taking into account everything. If you look at the dialysis procedure itself simply, cost accounting for hemodialysis becomes very challenging because you need to take into account the cost of building a facility, the cost of machines, electricity, water, et cetera. And yet when you look at PD, you have to look at obviously what the cost of the PD supplies here. My understanding in Pakistan, the cost of PD supplies is actually very low, lower than it is in the United States, which surprised me, or in Europe. And in that model, the cost of providing PD therapy should actually be very low. And the cost for PD, maintaining a patient on PD therapy with somewhere between 3 and 4 exchanges a day should be really no more than $4,000 by my calculations. Maybe that's something we can discuss later. So the important issue is, in a patient-centered care world, patients should be making decisions about what type of treatment they want. And what do we tell patients? What should we tell them about what are the outcomes comparing PD to HD? Are they really different? And is there advantage doing one or the other? And what's the impact of the treatments on health-related quality of life? So in the 90s, there were some early studies to suggest that certain types of PD patients, elderly patients, patients with diabetes, did worse on PD than HD. That hasn't held up. And most people think now the outcomes are identical for PD and HD patients, whether or not you have diabetes. On the left is data from Ontario, on the right is data from the USRDS, but the thing seems held up anywhere in the world now when you look at these outcome data. There is no difference in mortality rates between the two groups. There probably is a low hospitalization rate for patients on peritoneal dialysis. But importantly, the mortality rate for patients on peritoneal dialysis has really declined. And this is an important slide, again from the USRDS in 2018, showing the mortality rate of hemodialysis patients shown in blue and the mortality rate of PD patients shown in orange. And there is a significant drop in mortality rates from 2000 and up to 2016 in these outcomes. It seems to have leveled off now, but mortality rates have really dropped. And the mortality rates in PD have gone down, and I was discussing this at breakfast this morning. And it's really because of the impact of these international guidelines. So the ISPD has been terrific in making guidelines for the care of patients that apply across the globe. And this has resulted in significant drops in peritonitis rates, for example, and improvement in outcomes everywhere in the world. So peritonitis rates have dropped. When I started doing PD, which was in 1979, we were running infection rates 1 in every 12 months, for example. We're now running about 1 in 40 patient months. And if you look at data from PDOPS, and so that's the DOPS study now for focusing on PD patients, infection rates in Japan are extremely low, 1 in 80 and 90 patient months, and the averaging around the world in 1 in 36 or 40 patient months. And countries like Thailand, which have a PD first policy, have a very low infection rate. And I think perhaps Dr. Brown's going to discuss that later on this morning when she talks about peritonitis. There's been a decrease in exit site infections, better management of infections, improvements in catheter placements, better understanding of the psychosocial support necessary, better understanding of the dose of dialysis, which I discussed at the PD workshop on Friday, and better management of ultrafiltration. So the care of patients on PD has gotten a lot better. There are very detailed guidelines on the ISPD website that you can download for free that talk about how all PD patients really should be managed, and that has had a significant improvement, and me has been the driver in the improvement in outcomes in PD around the globe. So what about health-related quality of life? So the studies basically show, and this is from several studies, and I'm just going to give you a couple examples, that if you measure health-related quality of life using standard instruments, SF36, KDQOL, EuroQ, Euro 5 study, measure of health-related quality of life, there's no real difference in outcomes. This is showing you data here from the CHOICE study, which is a study based in Hopkins looking at new patients starting dialysis at the start and 1 year later, and studies from our program in New Haven looking at the MCS and PCS scores, which are the mental composite scores and physical composite scores in the SF36. And you can see those are the two graphs on the upper panel. There's no difference in outcomes. But if you look at patient satisfaction, that is how satisfied are patients with their treatment, and they're ranked by different score levels, which you can see here. And there really is no difference when you look at this. But if you look at the burden of kidney disease, again taken from the KDQOL or SF36, there is a significant difference here between the PD patients and the hemodialysis patients, confirming what I just showed you from our own studies, that PD has less of a negative impact on patient outcomes. On patients, the negative impact of therapy on patients. Okay, I'm going to shift now and talk a little bit about acute kidney injury, urgent start PD, and a couple comments on the future of PD and the opportunities for PD expansion. So again, we were discussing this at breakfast about the PD utilization for AKI. So 20 years ago, PD was the standard treatment for acute kidney injury. And this changed with the introduction of central venous catheters for hemodialysis and the proliferation of extracorporeal therapies and devices. And pretty much PD was abandoned in most European and North American dialysis facilities for managing patients with acute kidney injury. And everybody was put on hemodialysis. But this whole model shifted based on a couple of studies that came out of Brazil. And this is sort of the key study now. This is a randomized trial comparing mortality rates with high-volume PD and daily hemodialysis. And this was done in intensive care units in Brazil, so they're actually sick patients with high Apache scores, which is shown on the right there. But again, it's a randomized trial with 75 patients about in each group. And the patient outcomes are shown on the upper left. You can see there's no difference in outcomes. But the table on the bottom is really the important one. which is that recovery of renal function was more rapid in the patients receiving PD compared to HD, and there was more rapid resolution of the acute kidney injury. So remember that patients on PD with end-stage kidney disease have better preservation of residual renal function than patients on hemodialysis, presumably related to less incidence of hypotension, less problems with plastic exposure to blood, for example, and cytokine stimulation. But this study was very interesting, and it raised the question whether there really are adverse effects from hemodialysis in managing patients with acute kidney injury. And in fact, if you look at the data that Chris McIntyre, who was in the UK and is now in Ontario, has published, looking at the negative effects of hemodialysis-associated hypotension on myocardial function, cognitive function, endotoxemia, for example, because of bowel ischemia, one begins to wonder whether acute hemodialysis of patients with AKI may have not just short-term but long-term adverse consequences, and that there may be real advantages to using PD. So this was then confirmed in a randomized trial from Saudi Arabia, published by Abdullah Al-Houesh last year, and he compared PD now with CVVHD in critically ill patients in Dammam, Saudi Arabia. And importantly, he showed a better survival and shorter duration of dialysis in patients treated with PD. And again, this was about 75 patients in each group. So again, raising the question, is PD really being underutilized for managing patients with acute kidney injury? And based on these studies, now we've started to reintroduce PD as a treatment for acute kidney injury. So that brings me to the Saving Young Lives Project now. So the Saving Young Lives Project is a program that was started by the ISN, and it was started in response to a grant that the ISN got from Baxter to develop a program to manage patients with acute kidney injury in Africa. And when we looked at this, we decided the best way to do this was with peritoneal dialysis because it's such a simple treatment. It avoids the problems of electricity, machinery, et cetera. So the goal then was to provide educational support for the treatment of AKI in low-resource settings. And we've developed 16 sites, which are shown here, really through Africa and one in Southeast Asia. And what's important about this, the model we used to do this was we would find, there are very few nephrologists in any of these countries, so we would find a general internist or a resident who was interested in the project. We'd train them in another site. They would go to a higher resource country, South Africa, Brazil, European country, to learn how to put in PD catheters and the basic principles of PD. You could teach that in between 4 and 6 weeks. They would go back to their country of origin and start the PD program to treat patients with AKI. So this is, again, not nephrologists putting in cuffed catheters, treating patients with AKI with PD. Thus far, we've managed over 600 patients with AKI. Mortality rate has been about 25% in hospital. We focused on children primarily, so the mean age was low. Creatinine at the start was high. These patients experienced the ISPD developed guidelines for using PD for acute kidney injury. And we got together a group of people around the world to develop these guidelines. And the conclusions for this are the following. The PD should be considered as a suitable method of renal replacement therapy for patients with AKI. We recommended using flexible tunnel PD catheters. And again, there's no ideal method of catheter insertion, but the technique that was shown on Friday's conference, Friday's workshops, using the Seldinger technique with a peel-away catheter is the one that's easiest to use and the one that we use to train these residents or internists to put in the catheters. The dose of the PD, I didn't discuss this at length, but it's discussed very carefully in these guidelines that are on the ISPD website. You target a KTV of about 2.1, higher if it's necessary, and there's a whole description of why we decided that was the appropriate dose. We recommended that commercial solutions be used, but if you couldn't use that, it's easy to make your own solutions, and we gave formulas of how to do that in these guidelines using either normal saline, half normal saline, lactated Ringen's, Hartmann solution, whatever. It's very easy to do this, and they've done this now in several sites in Africa very successfully. The lessons that we learned from that are that first, that PD can be easily done to treat patients with AKI. Training physicians and nurses to PD was not at all difficult. We did this very easily from extremely low resource countries. Cuff catheters can be easily placed at bedside by internists or nurses using the Seldinger technique, and the complication rate was extremely low. Infection rates were surprisingly low with this procedure. So it was a very easy thing to do. And part of the outcome of the Saving Young Lives thing was there's been whole interest now in urgent start PD, and I think part of it comes from our experience in Africa, training these physicians in low-resource countries to put in the catheters, and the fact that you could put in the catheter and use it right away. So using the Seldinger technique, where you use a small needle, a guide wire, a dilator, and the catheter placement, you can use the PD catheter right away, and the leak rates or complication rates are extremely low. So urgent start PD is at the initiation of PD within 2 weeks of catheter insertion, or even right after the catheter is placed. And the reason this has gotten so much attention around the world is the recognition of the increased mortality risk with urgent start HD patients. So someone comes into the emergency department, is admitted to the hospital with advanced renal failure and needs to start dialysis urgently, which commonly happens in the United States, for example. You're much better off starting them on PD than HD. And you're putting the catheter with the Seldinger technique and using PD and not HD. So this works very well. And the key study on this is this one from Jeff Pearl in Canada, again, looking at survival rates by modality and access type. And you can see here that patients who start dialysis with a central venous catheter have a significantly higher mortality rate than those who start with PD or an AV fistula or an AV graft. And this is data from the Canadian registry. So this data has really driven the PD, and the experience we got in Africa with the Saving Young Lives program has really been important in saying that, yes, you can put a catheter in, you can train almost anyone to do it, the complication rate is low, and it works very well. So based on this, there have been papers now from all over the world, so they're shown here on urgent start PD. It works, it's a very successful thing to do. Outcomes are really very good. Okay, I just want to say a few words on new developments in PD and conclude with a final recommendation for what should happen in setting up PD programs in lower resource countries. So a redefinition of high quality PD, this is something that's important and is discussed by Dr. Brown, that the definition of high quality PD has really shifted away from focusing on dose of dialysis to looking at a holistic approach, focusing on patient outcomes and health-related quality of life and what's best for an individual or patient. This is a paper that will be published in PDI very shortly, and it's a very important paper because it changes the whole way that we actually think about peritoneal dialysis. We talked about low GDP solutions at this session, the workshops on Friday. I mean, these are solutions that are more expensive than commercial solutions, than standard PD solutions. The trick here is to sterilize the solution but not generate low glucose degradation products which stimulate inflammation in the peritoneal membrane. They're more expensive, they're not approved by the FDA in the US. We don't use them, the value of them is uncertain. And it's not something I think that is at all appropriate for Pakistan. Online generation of PD solutions, there's this new generation of PD cyclers that have come out, which technically will be complicated in the sense that you're going to make online generation of PD solutions, but it's going to reduce the cost of PD therapy probably and simplify the procedure. And this is an interesting outcome. There's some pilot projects going on that now in Singapore, and this is an interesting thing to follow. How practical this will be, I'm not sure about. And lastly is the expansion of PD in both high and low resource countries based in part upon the recommendations of the ISN. So let me just show you a couple things on that. This is a model of how the wearable PD system would actually work. So it's a compact system which will use 2 liters of dialysis solution, which regenerates by running over the adsorbent cartridges shown here. How practical it is to walk around this for X number of hours, I'm not sure. Whether people can use this at night while they sleep, I'm not sure about. How technically this will work. Managing ultrafiltration presents problems with this model, but this may in fact be part of the future of PD. It's interesting to watch and see how this develops. I want to mention the ISN Affordable Dialysis Prize. This was a prize the ISN gave out in Mexico City. They gave an award for, they put out a request for proposals for a low-cost dialysis procedure or machine. And the award went to an Australian who came up with this model of using solar panels to heat water from a local source to make steam, which is then used to which then condenses as purified water, mixes with concentrate, and generates PD solution. When I heard about this, I wasn't sure how you could commercially use this solution, but apparently this is being developed in Australia by the George Institute, And there's some models that are going to be tried out in the near future. I haven't quite seen how they work, but this could be a very interesting way of reducing the cost of generating PD solution. Again, how practical it is, I'm not really sure. It's something to watch. But I want to conclude with this last slide. What are the things that are necessary to establish PD programs in resource-limited settings? And this is, I want to go through these and just mention them all briefly. So first is educate doctors and nurses in the basic principles of PD. This is easy to do. This is not complicated. PD is simple. It is not rocket science. All the guidelines are laid out on the ISPD website. We've done this in Africa very successfully and set up PD programs. Very simple to do. Secondly, you need to adapt the ISPD guidelines to available resources. So again, you have to look what antibiotics are available, how practical is it to generate solutions, how much solutions can you get, etc. But everything is laid out on the ISPD website. It's easy to do. You have to develop infection control and training protocols, and this needs to be developed locally to conform to what the available personnel are and resources you have. Again, it is not difficult to do this. You need to train nephrologists and surgeons on techniques of catheter placement. Again, this is easy to do. We've done this in Africa very successfully. Importantly, you need to establish a database, a registry to track outcomes. That's one of the key recommendations of the ISN Summit meeting. You can't just let programs develop. If they've got very high infection rates, high mortality rates, you need to understand why that is. It's essential that you get good quality control in there, and the only way to do that is to have a registry and track the outcomes carefully. You need to negotiate a reliable supply of PD solutions. Patients don't get solutions, they're going to die. So you have to make sure that you've got solutions coming in on a regular basis into the country, either manufactured locally or coming in from an outside source. That's absolutely essential. You have to have adequate hemodialysis backup and support. Remember that 10 to 13% of PD patients transfer to hemodialysis every year. You have to be able to have a hemodialysis backup for these patients. They transfer because they have infections, the catheter doesn't work, whatever. But you have to have that backup system. You have to have a referral system for transplantation, obviously, and that's part of any end-stage kidney disease care. And lastly, you have to have patient advocacy, education, and support. Patients need to know that this treatment is available and can be done at a reasonable cost and integrated into the government healthcare finance system. So patients have to know about this. You have to educate them. And again, if patients do make choices, the lesson from Australia, from the UK, from Canada, is that 30 to 35% of patients will choose PD if given that choice. So let me stop there. Thank you very much.
Thank you, Mr. Finkelstein. The peritoneal dialysis is certainly underutilized, the mode of renal replacement therapy in Pakistan. I think it needs to develop, like any other countries. The many other developing countries, they are utilizing the peritoneal dialysis. And so we need to develop it and let it grow. And then certainly your help and with the help of ISPD, I'm sure that it will grow. So it is a tradition that there is no question asked after the plenary lecture. So thank you, Mr. Finkelstein.
Excellent presentation. I had a question about your experience with the African countries. What was the infection rate in these patients? Because the main concern that we have here in Pakistan with PD, and I see this with a lot of physicians, is that we can't do PD here because the infection rate would be much higher. I haven't seen any data to suggest that, but have you seen any of that in the third world countries in Africa?
Yeah, I guess in people I've spoken to in Pakistan and over the last week, that issue keeps coming up. I think the only thing I can suggest with that would be, If you look at the data from Thailand, infection rates are really extremely low, and Thailand is, in some ways, might be similar. It's got high temperatures, it's got high humidity, people are poor and they live in rural areas. Mexico is very similar. Remember, I showed 90% of people were on PD in Jalisco state, which is a very poor state south of Mexico City. Infection rates are no different than they are elsewhere. There are very nice studies from Brazil showing that socioeconomic status has no impact on infection rates. And again, this is poor people living in rural areas, living in the jungle areas in the Amazon, for example, do not have higher infection rates. The infection rates in Africa are higher than they are in other countries, but this is using sick people in the hospital with acute kidney injury. So those infections run about, they run about 10% of the people get infected. I believe it's something like that. But if you look at other low-resource countries around the world, infection rates are not really higher than they are in higher resource countries.
Thank you.
Okay, one more last question.
I just want to give a little comment. It was back in 1995 when I came from London and joined Nistar Hospital, Multan. We received 2 young patients in a very sad railway accident with crush injuries. So I had only 2 machines and I didn't have any hepatitis B positive dedicated machine. So what I did acute peritoneal dialysis for 12 days, and both the patients, they fully recovered. So certainly it's a big tool, especially in third world countries where we have got less resources. So I just wanted to add this thing, that it can be done in acute setting, and especially when patients come to you with very low hemoglobin, and they are having acidosis and all that in the middle of the night, and you don't have hemodialysis facilities. So it is a very big tool which is very much underused in Pakistan. Thank you.
Good. It's nice to hear that that experience here is positive as well. Thank you.
I will like to request Professor Fazal Akhtar to please present a shield to Dr. Frederick Finkelstein. Thank you, sir. I urge all of you to please download the PSN app from the Google Store, as there is a following debate on blood pressure targets, and the voting will be done via the app, please. So download it from the Google Store. Thank you.
Thank you very much. Now we will start the next session, that is the debate on target of hypertension, blood pressure control. For this, I request Professor Azman to come on the stage for the moderation of this debate. Let's start our meeting. So I request Dr. Kamar. Sir Azaz, kindly come on this, and you have to moderate.
I can do it from here. Assalamu alaikum and good morning, everybody. So this is going to be an interesting session, and we have 4 speakers here this morning. 2 are for the target blood pressure, which is lower, and 2 are for a little liberal blood pressure control in CKD patients. The rules are that we will give about 8 minutes, about 8 to 10 slides to each speaker, and the panel of experts. We have Professor Yaqub Magdi, and I will request him to kindly come on the stage as the chair of this session. Professor Yaqub.
Okay. You have to can you hear me? So you guys have to give me 1 more minute. This clock has to be reset, I guess. It's already 8 minutes. So my name is Kamar Khan. I'm a nephrologist from the United States, and my practice mainly consists of hypertension, CKD, and stone disease. So this is very close to my heart, and I'm very aggressive in my clinic to control the blood pressure of my patients. And when this topic was given to me, I decided to go with the aggressive blood pressure control, and let's see what we decide. So I was going to show this as my last slide, but I'm going to show this right now. Keep this slide in mind, and then we'll talk about it in the end, if I can get to the end in 8 minutes. So reasonable people can disagree. I mean, we all treat blood pressure, and we all go by guidelines. We all go by go by different guidelines, and guidelines are just guidelines. So you need to use your experience, your expertise to treat this common condition. And we have various guidelines, and United States, we have like probably 6-7 guidelines. Okay, that's fine. So most of the guidelines are like out and available. This JNC guideline was the guideline that we were using in the past, most of the people, and they went along with the AHA guidelines and other guidelines from Canada, and it showed. I mean, this guideline had same kind of blood pressure recommendation for high cardiovascular risk patients, and it was fine until 2008, when this guideline came out and just started giving some different cutoff blood pressure for high cardiovascular risk patients, elderly patients. And I have to give you a little background of this JNC8 before we go to the next one, that this JNC8 had like 45 members, and then in the end there were only 17 members, and the people who the decision was made by 2/3 majority, and if one person had voted against that, the recommendation that they finally made, the recommendation would not have changed. So one important slide, I know that I have little time, but is important slide to keep in mind is how we could check the blood pressure. So most of these newer studies, they had oscillometric devices that they use to check the blood pressure, and those devices give you slightly lower blood pressure when they are checked in the office, and they go more like in line with the home blood pressure readings, and home blood pressure readings are what we really go by, and that's one thing that we need to keep in mind. And so this is another slide that shows you how important the home blood pressure reading is, and many times we have resistant hypertension or white coat effect. We see them in the office having high blood pressure, and at home they have like normal blood pressure. So masked hypertension is just the opposite. So what about the goal blood pressure and CKD? So goal blood pressure and CKD is considered as like a high cardiovascular risk patients. I mean, this is pretty much decided. The studies that I'm going to talk about, they'll talk about CKD and patients without proteinuria, and I mean they had. So we have like different studies. We have observational studies, randomized trials, but the most important are randomized trial. And I will just briefly discuss some of the. We have very few randomized trials. That's an important thing. I mean, in cardiology, you have like huge studies, but in nephrology, we have very few studies. And these are all the randomized trials that we can come up with. So MDRD, this was an important study, and it showed trend towards improvement if you go by the blood pressure goal. So 92 mean arterial pressure is somewhat close to about 125 or 70. And this study was, there was a cohort phase, and that phase also, that phase also showed improvement in the cardiovascular event. So then the next study that, there was, okay. So the cardiovascular, the cohort phase also showed something somewhat similar result, and then we had this RAIN-2 trial. I mean, if you see the RAIN-2 trial, that didn't show much of a similar result because the difference in the blood pressure was only like 4 millimeter. The most important study that I would want to mention is the SPRINT trial. And the SPRINT trial is the most important trial that was published. If you see that the number of patients in the SPRINT trial is probably even more than the total number of patients in all the studies. And this is the bottom line, the SPRINT trial. And it did not include the patients with proteinuria, because proteinuria, we have already kind of decided that with patients with high amount of protein in the urine, you go with a lower blood pressure goal. But if you have less proteinuria, and I'm not going to talk about diabetics because Accord was the trial that discussed the diabetics, and Dr. Shafiq Chima is going to be talking about that. And these were the criteria or definition of the patient that they picked. And there was higher incidence of like side effects as you expect. If you have like higher, you want to like drive the blood pressure low, you always have people having side effects. So, but in general, if you see all the CKD trials, the lower blood pressure goal, as you can see in this slide.
Your time is up. Sorry.
Okay. So this is the final slide, and this shows that
if I say stop, I think you will have to, like a headmaster.
What is that? Okay.
Sorry.
All right, that's fine.
I
hope this part is not recorded.
In the debate, it got to be sticking to your time. I think it's unfair to the other speakers then.
All right, let's get the other speaker up.
Please, thank you. I apologize. I really don't want to do this.
Okay,
we are enjoying your talk, but I think for fairness, we have to be 8 minutes, and that's it. Thank you.
I think there's an app. On that app, you can score. Just look at the app there, and there's the debate. Just click that, and whether you agree or disagree.
But the final decision will be ours.
Yeah.
You call the second.
Dr. Ali Khan. Just to remind, 8 minutes.
I think he's got that habit of.
Assalamu alaikum and good morning, Honorable Chair, moderators, my fellow delegates. I shall be speaking on the motion and will convince you that blood pressure goals in diabetes should be liberal, not strict. And I disagree with Dr. Kamar, and I'll show you what that disagreement is about. All right, so this is a quote that I would start with. In the absence of clearly defined goals, we become loyal to performing daily acts of trivia. And I think that's what we are doing today. So as you all know, diabetes is a major risk factor for cardiovascular disease. It is well known that almost 70% of our patients with diabetes die of cardiovascular disease. Hypertension is a well-known risk factor for all major cardiovascular disease. And the presence of hypertension and diabetes significantly increase the risk of myocardial infarction, stroke, and all-cause mortality in our patients. So what is this debate about? So what is the optimal blood pressure targets? So I'll show you first what the guidelines say, and I disagree with Dr. Kamar. These guidelines are, developed by very smart people after many, many hours, and we should not just, throw them out of the window. So these are the major guidelines you can see. ADA, less than 140/90. Special cases, you can do 130/80. American College of Cardiology, AHA, less than 130/80. JNC 8, less than 140/90, and you can read the rest. There is none that says less than 120/80 is recommended for diabetic patients. So this is my mentor from fellowship, Dr. K.K. Venkat. He used to say, in God we trust, everyone else has to bring in data. And this is the data that I'll show you. The largest trial, as you know, is a CORD trial in diabetic patients looking at low versus high blood pressure control. This was a multi-center randomized trial of almost 10,000 patients. And you can see there was a 14 millimeter difference in the treatment arm versus the usual therapy arm. And there was no difference in primary outcomes in these patients. And the intensive therapy actually did reduce the risk of stroke, but as you can see, the complication rates were very high in intensively treated patients with regards to hypertension, bradycardia, hyperkalemia, and so on and so forth. Some of the other major trials that we all know, hypertension, optimal trial, heart trial, they looked at diastolic blood pressures, mean achieved 82. UKPDS 144/82 was the mean achieved in treatment arm. ABCD trial, mean achieved 133/78, but no difference in primary outcomes between the treated versus non-treated patients. Advanced trial, major trial looking at placebo versus prendelopril and indapamide. You can see the average blood pressure achieved was 136 millimeters of mercury in patients who were treated. In West trial, they looked at 3 groups, less than 130, 130/40, and greater than 140. The rate of all-cause mortality was significantly higher in control group, tight control group versus the usual control. And during further follow-up, that mortality risk remained in patients who were tightly controlled. And systolic blood pressure of less than 115 millimeters of mercury was associated with even more mortality for patients. Transcend, another trial, diabetic patients, 35%, 6,000 patients looked at, no cardiovascular benefit, as you can see, in treatment arm versus control group. These are some of the other trials. As you all know these, SHEP-DM. What I want to focus on is the achieved target in these trials. You can see achieved active group 145 in SHEP-DM, IDNT 140, Renal 143, advanced trial 134, and all had 136. Hot trial DM was 144. None of these trials had less than 120/80. You have to look at these trials. These are placebo-controlled, randomized trials, and they show that if you try to control these blood pressures down to lower levels, you end up having more mortality risk and more adverse events. So in conclusion, there is no clear data, and I repeat, no clear data in randomized controlled trials that show less than 120 millimeters of mercury systolic is beneficial based on data. Most international guidelines done after hours and hours of looking at this data and show less than 140/90 is the target blood pressure and not 120/80. More side effects noted for strict control versus less strict control. And blood pressure targets, in my opinion, needs to be individualized in patients and not a blanket target for patients with diabetes should be given of less than 120/80. And with that, I end within 8 minutes.
Thank you. So now we have our next speaker, Professor Shafiq Chima. He's going to talk about about the tight control.
I could never
talk about liberal. My name is Shafiq Chima, and just in 8 minutes, I'm going to show you enough evidence that why intensive blood pressure control is essential and why most guidelines are decreasing the blood pressure targets. So a famous ABCD trial basically randomized 470 patients and end up showing there is significant decreased reduction in the GFR as well as decreased progression to micro and macroalbuminuria in patients with intensive blood pressure control. And then the Accord trial, they just talk about. This Accord trial is a randomized trial, multi-center, done in different sites in North America, where the main question was if the strategy to lower blood pressure less than 120 is better as compared to strategy to lower blood pressure less than 40 in terms of reducing cardiovascular events as well as mortality. And it did show a 12% benefit, even though it was not significant. They said it did not show any benefit. And then there was a significant benefit in stroke. The significant benefit like SPRINT was masked by the intensive glycemic arm. So if you have to compare, and we all know hemoglobin A1C of less than 7 increases mortality, and it's not recommended by most of the guidelines. So if you have to compare intensive blood pressure with intensive blood pressure, you have to take a standard glycemic arm because the intensive arm was terminated earlier at HbA1c of 6.6% because of increased mortality. So you have to compare standard glycemic arm, intensive control versus standard control if you want to really get to the data. And I would quote two studies, one by Leo Buckley, in which he showed that intensive arm did significantly better in the Accord blood pressure, just like SPRINT, but you have to take the standard glycemic arm. So he took SPRINT eligible Accord blood pressure patient with one additional risk factor and showed that intensive blood pressure is better, and he ended up concluding that intensive blood pressure control reduced cardiovascular outcomes in cohort of participants with type 2 diabetes mellitus with one additional risk factor. And then the SPRINT and Accord in standard glycemic arm is compared again in 2018 and published in Journal of American Heart Association. The baseline characteristics in both groups were similar except for diabetes. And let me show you, this is a randomized control data, post hoc analysis of Accord. A significant benefit in SPRINT, we all aware of that. The benefit would be as significant in the intensive arm as long as you use the standard glycemic arm. We are not debating here to talk about intensive glycemic control. We are here to talk about intensive blood pressure control. And it would be significantly different if you are using intensive glycemic arm. So there is something in diabetics which was making the data get the worse results. And exact same effect for the mortality. The first slides were for the cardiovascular effects. And if you look at the mortality, exactly similar data favoring as long as you have the standard glycemic arm, the intensive blood pressure is better. And let me show you SPRINT patient, 930, around 10,000. And if you compare them with standard glycemic arm, the p-value is not significant. All the data, the randomized control trial, they favored intensive control. The outcome was exactly the same in Accord as long as you use the standard glycemic arm, because the p-value would be very significant if you are comparing that with either with the whole group or with the intensive group. And this could be shown in another way. This is before the intervention. You could see intensive arm is not doing that good. This is in years. But then you look at in months after the discontinuation of the intervention. So once you have discontinued the glycemic intervention, look, intensive arm is doing so good. Intensive arm has a significantly decreased risk of cardiovascular disease events and mortality. So they end up concluding that effects of intensive systolic blood pressure control on cardiovascular risk and all-cause mortality were similar in patients without diabetes and with diabetes, but as long as they are on the standard glycemic arm. So there might have been some interaction which masked the beneficial effect in the intensive glycemic arm, and we all know currently that myocardial cells cannot withstand ischemia as good in diabetics. So if you have to compare a standard of treatment. So they would also show you, and they have shown you, there is increased incidence of hypotension and more drop in GFR. But why then there is no significant increase in the risk of end-stage renal disease? The reason for that, there was no tissue injury. The drop in GFR is the hemodynamic effects, just like RAS inhibitors and SGLT2 antagonists. And that was shown in the post hoc analysis in which they took 529 patients. And these 529 patients then divided into two groups, intensive and standard. And then they took 4 markers of tissue injury, of inflammation, fibrosis, and all that. Even though the intensive blood pressure showed lowering of GFR, but it did not increase all markers of kidney injury. In fact, there was significantly more drop in albuminuria. So this signifies that the effect of intensive blood pressure in terms of some slight decrease in GFR is not the tissue injury, it's not the kidney injury, it's a hemodynamic effect. So based on this ample evidence, I'm going to summarize that accord blood pressure, standard glycemic arm showed reduction in cardiovascular events and all-cause mortality with intensive blood pressure lowering, similar to SPRINT. And treatment-induced creatinine elevation with intensive blood pressure control are not associated with intrinsic kidney injury. And this effect is similar to ACE and ARB. So if you do not want to see your patients with increased cardiovascular events, as shown by liberal control, increased mortality, worsening kidney injury, albuminuria, then you must go with overwhelming evidence and vote for intensive control of blood pressure in diabetics. The evidence is so convincing, they keep on quoting the wrong guidelines, that the current guideline by American Heart Association, American College of Cardiology, KDOQI, has to decrease the target blood pressure to less than 130/80 in patients both with and without diabetes. So my only last word is, you win or lose, but I would suggest my opponents that they must decrease the blood pressure in their patients with kidney disease, with and without diabetes. And I also finished in 8 minutes. Thank you.
Now we invite our last speaker, Professor Salman Shafi. He's going to talk about the liberal control in blood pressure.
Okay, so I'm going to discuss the target blood pressure in patients with CKD, and I will argue for a target blood pressure less than 140/90. Now, intensive lowering blood pressure is great. It gives us more work and provides us with more challenge. But does it really affect patient outcomes? So I'm going to put that in the form of questions. In patients with CKD, does intensive lowering of blood pressure slow down progression of CKD? Does it reduce mortality? Is it safe? And the kind of data I'm going to look at is the high-quality evidence, either randomized clinical trials or meta-analysis of randomized clinical trials. It means no observation studies, no post-hoc analysis, no secondary or subgroup analysis. Now, the post-hoc or secondary analysis are done once the main results are negative. They are done by excluding patients, creating new subgroups, just to create a positive result, but any meaningful recommendation cannot be made based on these post-hoc analysis or secondary analysis. And the classic example is the blood pressure target less than 130/80 in patients with proteinuria. It's a grade 2D recommendation by KDIGO guidelines, so that is a very weak level of recommendation. So let's start with the first question. Does it affect renal outcomes? So we start with the old studies, the MDRD, ASK and RAIN2. Basically, predominantly non-diabetic studies. The ASK was done in African American patients All three studies looking at the same question, whether intensive lowering of blood pressure affect renal outcomes. And despite some variation in definition of renal outcomes, all of them reached the same conclusion, that there is no difference in renal outcomes. Now, the MDRD and ARS trials are also famous for their extended follow-ups, and I'm going to show you their final conclusion. So decades after conclusion of MDRD and ARS trials, the incidence of end-stage renal disease was assessed via USRDS database by combining patients from both studies, and there was no significant difference in risk of end-stage renal disease between intensive and standard blood pressure groups, even though this type of information qualifies more as an observational data because of lack of active follow-up. And finally comes the famous SPRINT trial. The SPRINT has a pre-specified subgroup of CKD patients that was supposed to be analyzed and published separately. So published 2 years later, after the main SPRINT study, about 28% of patients in the main trial had CKD. Like the main trial, they were randomized to SPP less than 140 and less than 120. And let's look at the renal outcome between the two groups. Absolutely no separation, no significant difference in renal outcome. So the answer to the first question is pretty clear. It's a glaring no. Next, does intensive lowering of blood pressure in patients with CKD reduce death? So I will come to the CKD SPRINT again. Even though there was no significant difference in renal outcome, an impressive 28% reduction in mortality was found in the intensive group in CKD. But there are a couple of issues as far as the practical implication of this finding is concerned. Number one, the method of blood pressure measurement in SPRINT trial was unconventional. They used an automated oscillometric device, Omron 907. The patients were left alone in the room, and the average of 3 blood pressure readings were taken automatically. And even this protocol was not strictly adhered among all patients. Now, in a separate study of CKD patients, this type of blood pressure measurement technique was compared to the standard clinic blood pressure, and the difference was 12.7 millimeters of mercury. But more important is the variation of difference. In a given patient, the difference can be anywhere from -46 to +20. So you cannot come up with a numerical expression between the conventional blood pressure and the unattended automated blood pressure. If you want to replicate the results of SPRINT trial in clinical practice, you have to use the same method of measurement. This device costs about $625, though there might be cheaper alternatives, but you need a separate quiet room. Now, more importantly, the results cannot be generalized to all patients with CKD. The conventional wisdom is that you should only apply the results of studies to the patients who were included in the trial. So on the left-hand side, look at the exclusion criteria. Younger patients, diabetics, stroke, patients with polycystic kidney disease, patients with proteinuria, patients with advanced renal failure, they were all excluded. So if you exclude all these patients, how many will be left behind? So this question is answered by an Italian study. Out of nearly 3,000 patients who visited specialized renal clinics in Italy, only 20% will match the characteristics of patient included in the SPRINT trial. Now I'm going to explore this mortality benefit further in meta-analysis, which compared intensive versus standard blood pressure control, including trials limited to CKD patients or CKD subgroups of general population, including SPRINT trial. And the outcome of interest for this talk is mortality. I'm going to present 3 meta-analyses, all post-SPRINT and all include SPRINT trial. The first one, 9 trials of over 8,000 CKD patients comparing SPP less than 130 and SPP less than 140, predominantly non-diabetics, no significant difference in mortality. The second one, much larger, over 16,000 patients with CKD in 18 trials. The reason they have more trials because they included 5 studies which compared treatment versus no treatment. Now, once you include those studies, you will not have any threshold or target blood pressures. All you can do is compare intensive versus less intensive and look at the average achieved blood pressure in each group. Yes, there was a 14% reduction in mortality in the intensive/treatment arm, but look at the mean achieved blood pressures in each arm. The mean achieved systolic blood pressure was 132 in the intensive arm and 140 in the less intensive arm. So it shows that you should go below 140, but it does not prove that you should go below 130. And the last one, if you limit your analysis to the fabulous four trials, AST, MDRD, Accord, and Sprint, you get 5,000 patients with CKD. Again, no significant difference in all-cause mortality. So the last question, is it safe in patients with CKD? So just one slide, data from CKD Sprint. Patients who were randomized to intensive treatment, there was higher incidence of AKI and greater than 30% decline in GFR from baseline and higher incidence of electrolyte abnormalities. Okay, these are not life-threatening complications, but they will certainly cause anxiety among patients and they will require additional follow-up, lab tests, and medication adjustments. So to conclude, intensive lowering of blood pressure does not slow down progression of CKD in patients with CKD. Regarding mortality, if you look at totality of evidence, there is no convincing evidence for a systolic blood pressure less than 130. Yes, in CKD Sprint there is, but it is limited by lack of generalization and unconventional blood pressure measurement technique. And there are adverse effects with consequences for clinical practice of intensive lowering of blood pressure. So I will conclude that European guideline recommending a target blood pressure of less than 140 over 90 is more appropriate for patients with CKD.
Thank you, every speaker. Apart from the first speaker, I apologize again to act like a headmaster, but all the three followed the instructions. So I'm very, very pleased. We should ask the audience, I think the speakers will not be allowed to answer the question. If you have got any burning issues which you think that they've missed, you can air it, which will help us both to summarize the debate.
Dr. Ahad, you want to say something about the app?
Sorry to butt in. So I just wanted to sort of urge all of you to please download the PSN app. It's available on Google Store and the App Store. So the voting will begin on the app at 10:15 exactly, and it will stop at 10:20. So you just click on PSN, the icon, go to 2019 conference. It's for them to upload the results, and then we'll see what they say. Yeah.
So any quick comments? We have just 2 minutes for that.
I don't think so. Anybody has questions? So if me and Ijaz, if we can just help the audience in summarizing what we heard, because sometimes they were talking too fast, so we have made our own comments. So if I start initially, that we heard a lot about guidelines. Some people were a little bit not so enthusiastic about guidelines, and some people were weighing too much emphasis on guidelines. So that is up to you guys. Should we change the name of the guidelines? There should be recommendations, loose recommendations. Guidelines is too powerful word in my opinion, and we use it. We heard something about white coat syndrome. I think there was a mention of masked hypertension, which is becoming very important. A lot of the studies which were discussed mainly focused on Sprint, Accord. RAIN was mentioned very briefly. MDRD study, which was mentioned by quite a few speakers. Accord was discussed a lot. I think Dr. Salman Shafi, Professor Salman Shafi was not very keen, but he didn't tell us why. At least it would have been nicer if he had said that what is the, we all know it, but it would have been nice for the trainees to know why post hoc analyses are all rubbish, or not rubbish, whatever way you look at it. The whole focus has been on systolic. And I just want to challenge the audience that we did not hear anything about the diastolic blood pressure. Not a single word was mentioned about diastolic blood pressure in the entire debate, which to me was a little bit disappointing, I must say, because when you see a patient, I don't look at systolic, I look at the diastolic. I don't want to bring that diastolic below 60 because we know that that is where the actual problem starts. So I was slightly disappointed that we did not hear anything about diastolic blood pressure. There is data, hot data is there in Lancet published 20 years ago. And the sad thing is that in the latest hypertension guidelines, they have reviewed 1,000 papers, 1,000 references in the guideline, right? And when they have made the recommendation of whatever we heard today, only 8% of those trials, or 8% trials, were regarded as class 1A, which is what you call based on RCTs. 92% of the recommendations are either moderate or weak recommendation. So I just rest my case that I was expecting that we will be focusing on people who have got established CKD or established diabetic kidney disease already in, rather than a GFR of less than 60. Not every CKD or every DKD is the same. I was looking at the clinical trials to answer this question, like RAIN study, which was purely done in proper, the patient which we see in our renal clinic. So that would be my slight criticism, that most of the emphasis were put in on post hoc analysis of the patients who just by backdoor entry got into the sprint trial or Accord trial or whatever. So I would have focused, if I was doing the debate, only on only 1 or 2 trials. If that is what you have to show for, go for it, and just go for those which is relevant for our clinical practice. So you can't change your clinical practice on the inclusion criteria of patients who went into sprint or Accord trial. So that would be my slight thing, but I must say that they did exceptionally well. All of them are top-class clinicians, so I'm not here to criticize or whatever, but as an expert, I had to say a few words, and if I had to nitpick, which what I'm doing, I thought that that was an excellent debate, fantastic debate, there is no two words about it, but, and we should have more of these in future. I think we should have one debate every day on your conference, which would be, I think, which focuses the mind of the trainees and everyone. So that's my recommendation. But that is my briefing expert thing, that you heard both sides of the stories, and I think we will take a vote and see who won or which group won. Is it the app will tell us, or?
Yeah, the app will tell us the results.
And you can summarize. We have got time. I think there's still, it's such a close call. I think there's only 1 or 2 votes in it.
I think the mean arterial pressure was mentioned, so that would perhaps take into account the diastolic. And as far as the method of recording blood pressure, different tools that we use, the electronic ones, the sphygmomanometer, etc. I think this has a lot to do with because these are not standardized. So comparing, different BP apparatus findings, that brings into some kind of a doubt or a bias as far as the results are concerned. So let's see what the House has to say about the voting. Or if it is taking too long, can we do it from the show of hands?
Show of hands, yeah, I think that would be better.
Show of hands,
okay?
Okay.
Because everybody is struggling with the WhatsApp. Okay. So
the show of hands. Okay. Oh, there you are. I hope this is not a guideline. So, would you like to comment on the results?
No, as I said, that this is, again, as I said, that I expected it to be much closer than what it was. If you were to ask me how I would have voted or how you would have voted, so I would just say, can we start with you? You are the blood pressure guru of Pakistan.
I would
Go for the liberal one.
Means I would be very honest that I wouldn't go for either of two. I would say that guidelines are the biggest enemy of personalized therapy. Guidelines are devised for a population. All the RCTs even, when you look at there, you get the averages of the whole group versus the other group. You don't get patient level data. And unfortunately, when we were designing the hypertension guidelines, we did not have the access of patient level data. So we were getting this 1,000, which I mentioned to you, 1,000 trials in 3 days. Going through that was a huge task. But when we did that, we did not have that data. So the heterogeneity of that data was not available. And that's the case which I was arguing. The first thing I was arguing in design of guidelines that we should change the name of guideline to recommendation, because these guidelines are now being used by the lawyers to take the doctors to the court, because it is a legal definition. Guideline is a legal term. So that's one thing. Second thing is that guidelines and all these things take you away from personalized therapy. We should be doing N equal to 1 clinical trial. The person sitting in front of you, we should be looking at him, gathering all the data, everything is urine. We have got a lot of, renal have been a very, very data-rich environment. We don't appreciate it, but it is much data-rich environment than the cardiologist and every other specialties. We look at this, take that patient in view, and then use conscious thinking based on what you think is appropriate for that patient. So for one patient, I would give blood pressure of 120/70. For somebody, I would give 140/80. It's based on granular data who is sitting in front of you. So I would say, for me, both goals are not advisable. It should be an individual-based clinical practice for that particular patient who is sitting in front of you. Guidelines are for the population. Doctor is for that patient who is sitting in front of you. And that's how I practice. N equal to 1 clinical trials, all of us in this room, particularly the nephrologists, have been doing it unconsciously for their life. We do that every day in our life. Oncologists have taken this to another level. When I was in America, I went to Sloan Institute, they were telling me that they send a tumor marker to proteomics, metabolomics, and genomics, and histology. These 4 parameters are fed into the computer, and computer tells them that which pathway in that tumor is active. And then there are 50 drugs which have been fed into the computer. The computer then decides that based on this information, these 3 drugs would be the best drug for this person. That's called N equal to 1 clinical trial, but based on this objective evidence. What we do is clinical evidence. We don't have the tools of omics. So when you and me are clinicians, we have got the information of RCTs, etc. But when we see the patient, we have got their blood pressure, we have got other things, we have got socioeconomic factors, everything is in front of you. We should be using those at the moment before we become that super specialist when we have omics as well. But I personally think that the way we are managing our patient is far better. Taking a history and examining the patient is like, for a Muslim doing a namaz, is ritual. It should be seen as a ritualistic practice, that the comfort which your hand gives to the patient when you're examining the patient, that is half of the treatment. Listening and talking to the patient and examining the patient. Even though you have got MRI, you have got echo, but putting your stethoscope on the heart, that gives comfort to the patient that doctor is taking interest in me. That is a ritual. We should not go away from that ritual. And this message is for the particular trainees. So I would have not voted for either. I would have voted for personalized therapy, and that's what I preach, and that's what I practice. on that how to manage such patients. Ijaz, you were saying?
I think you've already alluded to that.
As I said, choose the lesser of the two evils. Okay? We are not living in a perfect world. In your house also, if there is something, sometime with the economic constraint, you settle for the second best. It should be no different from the patient. Okay? If I have got a choice that I will give 1 month extra dialysis free, but a horrible quality of life, I will make that choice discussing with the patient. So everything is this. But there are two big trials on isolated systolic hypertension, which were done in a group of people which you are talking about. They did not include CKD patients. So I can't say what it would be in CKD patient. There were some, but I don't believe in post hoc data. Fully I agree with Professor Salman Shafi that post hoc data should be, I would say, should be a hypothesis generator and should be studied separately in future studies. That's the only thing we can say about post hoc data. But there were two big studies. One was done in China and one was done in Europe. And they took the patient, and if you look at the mean diastolic blood pressure, mean I'm talking, is around about 64. Elderly people, and the systolic blood pressure was 180 odd in both groups. And they went and lowered the systolic blood pressure. And what they ended up was with the mean diastolic of 58 or 57 in both, around about that, just a little bit below 60. And they did manage to lose blood pressure below 150 in both of them. The only advantage seen there was in stroke prevention. Every other outcome was different. And also bringing to my friends, in a sprint trial, which is much more talk about, there are a lot of study design issues. First of all, it was finished prematurely. They were also elderly patients. If you finished any study prematurely, you overestimate the benefit. That is the biggest problem. So if it was a relative reduction of 0.25, if that study had been continued for 5 years, which was the thing, HR, according to the trend, would have been 0.15. I can tell you, I know statistics, so I can tell that it would have been, if that study had continued for 5 years, the relative risk would have dropped to 0.15. If you look at the MACE, which was the main thing, in sprint trial, it was driven by heart failure. MI as well as stroke, if you look at it, they were just missing the significance, though there was some benefit. And if you have heart failure being a driver of MACE, then you need to look at diuretic use. And in the intensive arm, there were more diuretic use in sprint study than in the less intensive arm. So one could quite easily say that that heart failure MACE driven was purely diuretic driven. There are a lot of issues. You can go into the granular issues, and these were the things which we were talking about when we were designing the guidelines, the latest guidelines which are going to come out. But having said that, this is what you have got. So in coming back to isolated systolic hypertension studies, stroke, yes, nobody wants to have a stroke. I don't want to have a stroke. I don't mind dying in my sleep with an MI, believe me, if my end comes. But nobody wants stroke or amputation. These are the two things which nobody likes if you ask the patient. In that study, they did lower stroke, but no other variables were thing. And they did not see. But when they did post-hoc analysis, I don't believe in them, they could see high incidence of MI when the diastolic fell below 55 in these elderly patients. Again, word of caution, they are not CKD patients. They are not DKD patients. I don't believe that in a 75-year-old, GFR of 55, particularly in a woman, is CKD. I don't believe without proteinuria, okay? I really don't think, and we have been over-egging the incidence and the prevalence of CKD, particularly in elderly people with low body mass, and particularly in our female colleagues. So I would say that until unless you have got proteinuric, CKD or DKD, The rest of the CKD could be hemodynamic effect of all the drugs which they have been taking or whatever. So you need to look at that patient who is sitting in front of you. I cannot advise you based on those two clinical trials. If you have got a person who has got MI in the past, already has got 2 stents, and diastolic is around about 62, I'll run a high systolic and not compromise his circulation of the heart. So it's depending on the patient. You know, and I'm sure you do that. I'm 100% you do that. But the pressure of these guidelines is coming. So we are now swaying, even the experienced clinicians are swaying in this direction.
I think the dialysis patients are a different ball game altogether. With their fistulas and everything, how low can you go? So I think we all confront such problems. Thank you very much. It has been an excellent debate, and I'm thankful to all the speakers and to the chair of this session, and for your active participation. And now is the time to distribute the shields, and I will request Professor Magdi to kindly give these shields to the speakers. And this is followed by the tea break. So if you have other questions or queries, you can do that in the tea break. Thank you. So the first speaker, Dr. Qamar Khan, I will request you to kindly come to